brought to you by the Ajax Public Library. We are pleased that everyone could join us and our speakers for this important conversation. I'm Julia Campbell, Adult Services Librarian at the Ajax Public Library. Your hosts for this evening, along with myself, are Sarah Dodge, Coordinator of Community Engagement, Lynn Yates, Community Engagement Associate, and Andrew Burley, Community Engagement Associate, all from the Ajax Public Library. If you experience technical difficulties tonight, we recommend that you exit the program and re-enter. If you continue to have difficulties, please place a comment in the chat feature and a staff member will assist you. For our phone participants, please press *9 to request assistance. This event is being recorded and we will be posted on our library website for follow-up viewing. To this end, we will be turning off your webcams, voice, or phone so that you are not displayed in the recording. Our presenters will remain on screen with myself joining them at various points. Our format for this evening will begin with presentations from our three speakers from 6:30 to 7:20 p.m. and will be followed by a Q&A portion where your questions will be answered for the last 40 minutes from 7:20 to 8 p.m. If you have any questions throughout the program, please enter them into the chat, and phone participants, please press *9. If your question is not addressed during the forum, a staff member will follow up with you at a later date. We are pleased to have the following speakers with us this evening: Dr. Dan Ricciuto, Dr. Pepi McTavish, and Tiana Tilli. For our first presentation, I welcome Dr. Dan Ricciuto, Chief and Medical Director, Infection Prevention and Control at Lakeridge Health. He has also been involved in the development of antimicrobial stewardship programs on a regional and provincial level as past Medical Director of Antimicrobial Stewardship at Lakeridge Health and co-chair of the Public Health Ontario Antimicrobial Stewardship Advisory Committee. He is currently an adjunct assistant professor at Queen's University and the University of Toronto with an ongoing interest in quality improvement research with a focus in infection control and antimicrobial stewardship. Dr. Ricciuto will speak about the current hospital situation and its healthcare implications. Welcome, Dr. Ricciuto.
Hi, thank you. Good evening, everyone. So will you, Julia, share the slides or?
Yes, we will just pull up your presentation shortly.
Okay, well, it's great to be here. Please disregard any screaming children upstairs. They're trying to wind down. Can't promise that won't happen. So what I'll do is just go over, as Julia mentioned, some of the current situation and epidemiology in the community with respect to COVID, what's been happening over the last couple of weeks, how it's affecting us at the hospital level, and how it may affect us going forward, as well as things that you can continue to do in the community to try and stay safe and try and prevent ongoing spread of infection. So just wait till the slides are up.
My apologies.
Thank you. Then will you toggle through the slides? Thanks. So I'll just let you know. I want to go to the next one. So you can go back to the first slide. Sorry, the third slide. There we go. Okay, so our data is a little bit behind here, as it was really from last week when we put together the presentation, and I'm happy to say it's actually looking better over the last week than it has than it did last. So these data are up to and including January 18th, and they're available on the Durham Region portal data portal for COVID-19 if you ever want to see these data. But basically what it's showing now is a significant increase in cases beginning in the fall, really with a significant increase from just before Christmas and into now. And as you can see, there's almost a doubling of cases in the from mid-December to mid-January, and this really was probably due to significant gatherings around Christmas and the holidays, and also a ongoing movement and amongst community members. You can see a lot of the data is either due to outbreaks or close contacts with cases, but there are some data where we just don't know a source, so the ongoing community transmission, or there's just no information about them. And I'll just, if you can go to the next slide, we'll comment a little bit about Durham Region. So this really follows the Ontario trend very similarly in Durham and in Ajax as well. So you can see really from mid-December to now, we had a significant increase in case counts. I won't spend too much time on this other than to give you a bit of a picture of what's happening in the hospital on the next slide. Which is again from last week, but it's somewhat similar now, where we've had about 33 cases or so admitted to hospital, split between our intensive care units and our medical wards. Since the beginning of the pandemic, we've had 334. It's been a little bit higher now, successful discharges from the hospital. So these numbers now are close, but not quite at the peak where they were back in April and May, where we had probably about 50 patients admitted over a couple week time period, at one time. Though if we refer to the previous charts I was showing, it seems like the spikes are way greater now than they were. We have to remember that back in the spring, we actually weren't testing very many people. We didn't have the same access to PCR tests, and therefore it's not really an apples to apples comparison. However, from the patients being admitted to hospital, I think that's more real because it's we were testing all of those patients, and it was a data point that we can compare. So we're getting up there, and it's making us nervous. And just, as a comparator or something to reflect upon, ICU beds available across our hospital sites at Lakeridge are around 35 to 36 maximum number of beds. And so, there is a significant proportion that are occupied by COVID positive patients at this point in time. And not to mention the medical beds. So it is quite significant overall. I'll move on to the next slide and just speak a little bit about some data that was put out, and you may have seen this because it was in the media a couple of weeks ago. So these are data, and it's really what prompted I think this most recent lockdown. So these data are put out by the Ontario Science Table, and these data are also freely available on the internet. You can go through a full presentation in some detail. This is a little bit small, but I thought I would go through, the concerns. So when this was first released, sort of before the lockdown, January 11th, things were looking a little concerning, as I showed you previously, that case rates had gone up very significantly and were increasing at around 5% on average with a daily increase. And so what this does was giving us a projection that if things continued on the way that they were continuing 10 to 14 days ago, the expectation would be that in 2 or 3 weeks we'd have up to 20,000 cases per day. Right now we're about 1,700 cases per day. Two weeks ago we were 3,500 or so, and so this is where we or the province recognized that if we kept going the way that we were going to be in big trouble with respect to the number of cases, the subsequent number of people getting sick enough to be hospitalized, and mortality. And the top line here was sort of not quite a worst case scenario, but a scenario where if you look at some countries where, for instance, the new variant strains started circulating, which I'll touch on a little bit, then you could end up with, sort of very dire consequences. Over the course of a month, could have ended up with 40,000 cases. And this is just showing the exponential spread. Now, fortunately, over the last couple of weeks, with the lockdown and potentially some vaccination effect, though it might be a little bit early to see much, we've actually been able to decrease the number of cases over time, and we're about half as much as we were at that point. So that is actually great and really promising. I think we have a ways to go before we are out of trouble, though, which I can discuss on a later slide. So next slide. So this just really reiterates what I've been saying, but reflects not just the case rates overall, so not just the number of people that were getting infected, but the number of hospitalizations and ICU admissions, which were increasing significantly. So the orange ones are all inpatients in hospital that are not ICU, and then the red were ICU. And just to give some numbers that are up to date, we're still at about 400 patients. Right about this peak, we're at about 400 patients that are COVID related illness in the intensive care units across the province, and that's out of about 1,700 beds. So although the cases have started to decrease in the community, we've only leveled off with respect to the admissions to ICU. And just to be clear, so that's 400 out of 1,750 beds, but those beds are predominantly occupied already, right, with others that don't have COVID. So the actual vacant number of beds is actually quite small, and even with beds there, the staff that are available to actually staff and take care of patients is quite low. So again, this is part of the reason to sort of sound the alarm and say we really need to get things under control, because the pressure was starting to really climb in the hospitals. So the next slide, please. And I wanted to comment on this a little bit, because I think there's obviously a ton of and important discussion about how COVID can affect those that are older more significantly. And we know that the majority of fatalities across the province through both first and second wave relate to those living in long-term care facilities and of older age. So that's very significant. However, if you look, this is the age and gender of COVID-19 cases admitted to the intensive care unit. You can see actually that a large proportion of patients admitted to intensive care units are between 20 and 60, or even 30 and 60. And so it's this isn't a disease affecting just the elderly, and I wanted to make that point with this graph. Next slide, please. And again, this is similar to previous, and maybe I won't dwell on it, but it's just showing that if the case rates continue to increase, then we'd be well over our number of available ICU beds very quickly. And so if we were on the same trajectory that we were a few weeks ago, then in the next couple of weeks, we would have expected to fill every single bed in the province with COVID patients, and then still need to make room for the residual non-COVID patients in the ICU. So very, it was very concerning, and still is, although the pressure is off a little over the last week. And a couple more slides just to talk about the variant strains, because this is something that has made the media, and there's a lot of concern internationally about this. So just to go over, in case you haven't heard about what are being called the variants of concern, or VOCs, and it's basically just strains of the virus that have mutated, and they've mutated enough. Like, mutations have been occurring throughout this pandemic, but these strains seem to have mutated enough to act differently. So the virus seems to be behaving differently. So one of the most common ones is a variant strain from the UK, B1117 strain. And that has taken over in the UK since the fall as the predominant strain, partially because it seems like it's better able to spread. And so it's about a 30 to 60%, or on average 50% better at spreading. So that, I don't know if we didn't really get into it, but this reproduction number, which tells us which way we're going with the case counts, with one person spreading the infection to how many others. When that reproduction number, the R number, is 1 or greater, it means that one person will spread it to one or more people, depending on the number. So for instance, if it's 1.2, then one person on average will spread it to 1.2 other people. With this, it's about 50% more likely to spread with that strain. There's two others. There's a Brazilian strain and a South African strain that, or at least first identified there. And they're a little bit different. They may also spread better and be more efficient at spreading through the environment. The other issue with those strains is they may actually you may be less immune to those if you were previously exposed to a strain. Like they don't necessarily cross-react. And so there's a little bit of concern with those strains that the vaccines and or previous infection may not protect people against those strains, and or for very long. So if they do provide some protection, it may not be as long lasting as we would expect with the other strains. There was just a recent study showing that the current vaccine does seem to create neutralizing antibodies, which are antibodies that protect against the strain, but at a much lower level than the other circulating strain. So these are why they're called variants of concern. So there's some concern there, and it has been detected now in Ontario with some long-term care facilities experiencing outbreaks, and prevalence done across the province. So with Public Health Ontario lab testing samples, we've found some scattered cases. It does not seem to be predominating at this point in time, but it's definitely there and starting to show up. So the next slide actually just is taken again from the modeling data done previously, which shows that if the B117 strain, for instance, starts to spread in the community, and we did not have other measures in place like the lockdown, then we could start to see pretty dramatic rises in the prevalence. So really, a massive increase in the number of cases over the course of several weeks to a month. And this is similar to what happened, and I don't know if anyone's seen the data from the UK or Ireland just after Christmas. They basically were more or less flat and then suddenly just shot straight up over time. Part of it was that they opened up their restrictions right before Christmas, so there were a lot of gatherings, and then this strain had started circulating around the same time, and so it was quite dramatic. And this would be, a very difficult scenario, I think, for us to go through. Now, the measures that to keep the strain in check are going to be similar to keeping the other strains in check, only become that much more important. And so I think the lockdown, that we're going through now is working for this. The question is, when is it safe to lift that lockdown and or these more stringent measures? Because if this strain is starting to circulate and things get opened up a little bit too soon, and we're not able to keep up with the appropriate public health measures, then we could be in trouble again and experience, for instance, a third wave in the spring or summer, and that again would not something that anyone wants. So on that note, I have a couple of other points just to reiterate about how to keep yourself safe. And this is stuff that I'm sure you've all heard before, but if we go to the next slide, we'll just go over some of the basics. And infection control is my background, and this is stuff that we've been talking about in hospital infection control for forever, but it's still very important. It includes hand hygiene, either with alcohol-based hand rub or soap and water. And frequently, I saw a recent study suggesting that people surveyed more recently had performed less hand hygiene than they were performing during the first wave. I think it's still a very important measure in case, especially if you're out in the community, in case you contact the virus, it can still be transmitted through hands to mucous membranes, for instance. Physical distancing is still very important, in addition to masking. As well. If you do have to cough or sneeze, it's recommended to practice etiquette either into your elbow or into a tissue, throw that tissue out, and then clean your hands with soap and water. If you do feel unwell, the recommendation is to get tested sooner than later, especially if you've had any exposures, and self-isolate. And we have a little bit of data from Durham suggesting that people on average wait 3 to 4 days of having symptoms of COVID before going to get a test. If we can actually shrink that time period down, it's likely that we'll expose less people. So we have lots of capacity for testing in Durham at this point in time. So I'd say that's a message to spread. Don't be afraid to get a test if anyone's experiencing symptoms. And then probably the biggest and most effective measure, which is where the lockdowns come, which is why they work, is to minimize contacts and avoiding gatherings with others outside of your immediate household. And I think this is something we got away from in the fall. We saw the cases increase to the point where we've required another lockdown, unfortunately. Next slide, please. I won't go into the details here, but there have been a couple of analyses done, and this is one, just suggesting the most effective strategies at decreasing COVID. And so, again, these are just based on what strategies different regions or countries have implemented. And they suggest that things that seem to work are small gathering cancellation, closure of schools, border restrictions, using more PPE. So it's like masking, movement restrictions, which is kind of like the lockdown, or a full national lockdown. These things work. The closure of schools is quite debatable, as it's probably not apples to apples comparisons against different countries, different regions, different cities even. And so I'd say that's a little bit controversial, especially given the issues with keeping kids out of school for too long. Next slide, please. I just have a couple more that I wanted to touch on, just masking. I actually won't go into this too much, but this is kind of more from the first wave, the difference between medical masks and non-medical masks. Both are okay. And, the medical masks are available in sufficient quantities now where many will be wearing them in the public as well, and they do work well. Non-medical masks, you just have to be careful with what you use, because some work better than others. Actually, I'll show the next slide. I think I included it. Oh no, it's a couple slides down, but that's okay. Sorry, go forward. Other way. Keep going. And next. Okay. And back, sorry. Thanks, sorry. So just skipping through a little bit on this is when you are wearing a mask, I'll show you a slide on how to choose your best mask, or how to best choose a mask. But the other piece of this is when you are wearing a mask, you just have to be careful with it. So it should be well fitting. It should fit across your nose. You should be breathing through the mask as opposed to in and around. So if there's big gaps, it means it's just not fitting well enough. It should be cleaned if it's a non-medical mask that's not disposable. And just be careful with respect to touching your face, ensuring your hands are clean if you do have to readjust your mask, and same with after you do touch your mask, to ensure that your hands are clean. Gloves are not recommended. It makes it hard to clean your hands. You can cross-contaminate yourself or the environment with gloves. Next slide, please. There's some good data. So this is what I talked about with masks. There's some good slides and more information on masking from Public Health Agency of Canada, as well as on a number of sites available from Public Health. Next slide, please. Okay, that's all right. That one didn't show up. It was just a slide on the best choice of masks. So there are, in general, it's best to get a 3-layer mask. There's certain that are either 3-layer cotton or polyester mixes that tend to be best if you're choosing a non-medical mask. So that's something to look for. There are 2-layer masks with filters. They're okay too. You want to avoid the single-layer masks or the bandanas and other types of I guess face coverings that are not necessarily meant to be used as a mask for source control. You can look this up as well. Actually, CBC Marketplace did a nice examination of different types of masks. So I think I'll leave it there from my perspective, and we'll stick around as well for any questions after.
Great. Thank you so much to Dr. Ricciuto for your remarks. Just a reminder that questions continue to be accumulated throughout the presentation by entering it in the chat feature or by pressing *9 for phone participants. So now we will begin with our second presentation. I welcome Dr. Pepi McTavish. Dr. McTavish is the Associate Medical Officer of Health with the Durham Region Health Department. Dr. McTavish's focus at the Health Department includes infectious disease prevention and control, immunization, and sexual health. Today, Dr. McTavish will speak about the role of vaccinations within public health and the planned vaccination rollout. Welcome, Dr. McTavish.
Hi, everyone. Great to be here. I was here in the spring and it was great. There were a lot of great questions. I'm looking forward to the Q&A after as well. So let's wait for the slides to pop up here. My first slide is a data slide, so I can't start talking about it without the numbers. But I know there's already been questions in the chat about when you can get community vaccine. So we'll definitely talk about that today. Soon is what I hope. Soon. Perfect. So next slide, please. So here's just our current status. So if you were here in the spring, you remember me talking about our data tracker. It has come a long way since the spring. It was great then. It's even better now. So you can find our data tracker at durham.ca/COVID cases. If you haven't been there, I really recommend you go there. Even Dr. Ricciuto is showing one of our graphs. And I'm sorry, on your screen, on my screen, the boxes with all of our faces are covering the tail end of the graph. So sorry about that. But the current number of active cases we're following is 580. Even a few weeks ago, we were up over 1,000 cases. So we really have come down in the last, I would say, week and a half. I started to feel a little bit more comfortable with the decreased cases. We were seeing, 150, 160 cases a day, and now we're seeing about 50 to 60, but we're still managing 580 active cases. So that is a lot of work for the health department. There's 533 people still in home isolation. Unfortunately, 47 people are hospitalized in Durham, and 14 of those would be in the ICU, as Dr. Ricciuto was talking about. But we've done a good job overall. I mean, we hit the 10,000 mark for cases in Durham a few days ago now, and it's wild to think about where we are now from where we were in the spring. Unfortunately, there has been 272 people in Durham who have died, and the bulk of this, about 80%, has been those in long-term care and retirement home residents. And you can't see it, unfortunately, or I can't on mine anyway with the boxes, but you can really see the difference between the first wave and then the second wave. And the boxes are there, but you can see that we are over the hump of the second wave. We're starting to come down. And as Dr. Ricciuto mentioned, how the variants of concern are going to play in. If we have a new one come in and it takes over, will we sort of see a third wave or a bump of the second wave? I think it's still too early to tell, but we are getting over the hump in Durham at least, which is nice to see. Next slide, please. So this just shows again that same pattern, the first wave, second wave. So this is on our exposure tab. So if you go to our data tracker, this is the tab in itself, and this is an excellent way to see where we have been, where we're going. So you'll notice in the first wave, it was mostly blue. So blue is staff and residents in long-term care. And you can see that we have some of that in the second wave, but it's rumbling along the bottom, right, with a couple large outbreaks that people would have heard about in Durham. But a lot of it is household contact, and a lot of it is still community transmission. So household contact, it's expected, right? COVID-19 is infectious. And sometimes you can't isolate from your family despite best efforts, right? For example, you're a parent, it's very hard to isolate from your kids. So sometimes people make the educated decision that they're going to isolate together. So we do see about 35% household contact transmission. And as you can see from the red, that's been consistent, right? And the other piece is the community piece. So it fluctuates, it's about 25%. What that means is for when we interview people, when the nurses interview, about 25% of the people, we can't figure out where they get COVID. So they're called community transmission. They got it from somewhere out in the community. And that's been consistent. And that is, it's an interesting number, I find, because we don't feel that people are lying to us. Sure, sometimes maybe we don't get the whole story, right? People don't tell us that they were carpooling with somebody, or maybe they went to a backyard barbecue and perhaps they shouldn't have been. But people we find are mostly telling us the truth. So there's a good amount of people who don't know where they got COVID. And that's been consistent. Next slide, please. So these are our vaccines. So I know our last speaker is the expert here in vaccines. So all I'll just say is that we have two available, Pfizer and Moderna. We have Pfizer in Durham Region at our hospital. At the health department, we were hoping to get Moderna. We actually have a big freezer for Moderna. We don't have vaccine yet at the health department. And without knowing what vaccine we're going to get, it makes it very difficult to plan for where the vaccine is going to go in the community because they're all very different. So we're very good about flu and flu vaccines and other vaccines that we distribute to partners in the community. We do vaccine clinics, we're in the schools for the vaccine. So we're good at transporting vaccines, but if you have a vaccine, for example, that needs to be at -80, it changes how you're going to do your work in the community. So we don't know what we're going to get next. We thought we were getting Moderna, right now we don't know. But the next two that are up for review are AstraZeneca and then the Johnson & Johnson one. So maybe our next speaker will have more information, but at the health department, we have no vaccines yet. Next slide, please. So this was the plan that came back out at the end of December, mid-December, I'd say. So you probably recognize this from the news. So these are the 3 phases. So the first phase, it's very specific. Sorry, if you hear whining and scratching, I have a puppy who's trying to get in. The first phase was supposed to be specific high-risk groups, and you see that there. The population to be vaccinated was long-term care residents and staff, healthcare workers, adults and First Nations populations, and then home healthcare recipients. Phase 2 was going to be expanded a little bit, more healthcare workers, more congregate care settings, more people that are higher risk in the community. And 3 was supposed to be everybody. So it's changed a little bit because our vaccine has changed, our supply chain has changed. Phase 1 we're still in, it's tweaked a little bit, we'll talk about that. Phase 2 changed again, but phase 3 is the same. It's going to open up to everybody. So everyone just needs to be sort of patient as we work through this in Durham Region to get everyone the vaccine. So next slide, please. So this one, I don't expect you to see it. It's hard to see on my screen too, but this is basically just to show you this placemat, that this is a massive plan. This will probably be over, I would say over 2 years before we actually, okay, maybe not, 1.5 years before everybody is vaccinated really. But this gives you a good sense that it's everywhere, right? It's hospital, it's community, it's mobile, it's looking for high-risk vulnerable people. So there's a plan. It just shifts a little bit based on the vaccine. So if you look to phase 1 here, where it says those high-risk population vaccination, those 4 blue boxes, it's changed. So healthcare workers, a lot of them have been bumped to phase 2. Adults and First Nations, Métis, Inuit, a lot of them, unless they live in sort of retirement home or long-term care home settings, they get bumped to phase 2. Adult home care recipients, they've all been bumped to phase 2. So this just shows us that this is very flexible, very dynamic based on the available vaccine we have. Next slide, please. So this is what's happening in Durham for the community. So we're very lucky that our partners at Lakeridge got Pfizer vaccine early, and they were able to immunize all the long-term care home residents with their first vaccine, and then the high-risk retirement homes. But this is looking at when there's more vaccine in the community and it comes to the health department, how does it get out? How do we plan? How do we make this work? Because this is vaccinating a lot of people, as we'll see in the numbers. So we just need to be really flexible, and we are able to do that. We just have to plan for it. So there's an executive planning table. So that has my boss, Dr. Kyle, and some people from the hospital, and they have the direct oversight for planning in the community. And then the steering table where we have public health, we have family physicians, we have community care people, we have hospital staff there, and people plan for how we're going to get vaccine, how we're going to distribute it, how we're going to administer it, and what does that look like? Is that mobile? Is that the paramedics going out? Is that mass vaccination? Is it through pharmacies? I'm still not sure if pharmacies are going to have a large role because they've done a great job with flu vaccine. So family doctors, for example, they're great at vaccination, but how do we get them the vaccine if it's going to be at -80, right? So all these things are still at play. So there's 4 main working groups: vaccine distribution, administration, logistics, and communication. So I can tell you, I know there's frustration that there's no vaccine yet, but I can tell you that there is about 15 staff right now at the health department working full out on this. So it's a lot of work. And if you don't see us doing it, we're doing it in the background for sure. So next slide, please. So this is the immunization task force, mass immunization task force. So this isn't part of that community group. This is separate for the region, because public health would be leading this part with support from our regional partners, because, for example, we need help with IT from our regional partners. Perhaps we need to go to the community center in one of our municipalities. So we really need the regional partners to help us with this. But this is where, I wasn't at the health department for H1N1, but this is the work that public health does and is good at. We just need to figure out what vaccine we're going to get and then how we're going to roll this out to the community. So this is still we're still doing this work. We're going to have a pilot in a few weeks of a small clinic as a run through. We don't have vaccine yet, but we'll have a small clinic so we can scale that up with community. So all this work is undergoing right now. Next slide, please. Oh, did we go backwards one? I think we went backwards. Oh, we're still going backwards. So one more forward, perfect. So it's just some demographics for Durham Region. So I'm sorry I don't have a way to circle here, but you'll see the seniors 65 plus. We have just over 100,000 in Durham Region. So a lot of people that need to be vaccinated, sort of in that first group. The long-term care homes, we have 19. I mentioned that all residents in long-term care have received their first dose of the vaccine. In the high-risk retirement homes, so I understand all the retirement homes except 5, unfortunately, have been done, and that's direction from the province. The vaccine handling and storage sites are mostly family physicians' offices, so we're still figuring out what role they're going to play. I get emails every day from family physicians saying, please, let me do something. I want to be involved with vaccination. And then some are saying, I'm seeing mostly remote patients right now. It wouldn't be a good fit for me. So we just need to figure out who can do what in the community. And there's 142, I think it's actually a little bit higher than that. Now, pharmacy partners who provide influenza. So again, a great resource. We just need to figure out how they're going to play in to the larger COVID vaccination strategy. So next slide. So don't need to worry about the phases here because the last time the province updated this was actually, I think, the 13th of January, and it's changed a bit, as I mentioned, but this website is really important. And if you just Google Ontario COVID vaccine plan, this is the website that pops up, but it's a good one to have bookmarked because it'll refresh, right? And it'll tell you what the new phases are so you can keep up to date. So next slide, please. So this is what's come out in the media, and this is not yet updated on the last slide, those 4 purple boxes, but I suspect in a few days it will be. So we've heard that there's been Pfizer slowdown. So the main populations now are still the long-term care homes, the high-risk retirement homes, and then First Nations individuals who live in elder care centers. So there are still many health units in many areas that don't have any vaccine, right? So they're taking vaccine from areas that had more, perhaps, and have moved it. For example, we were supposed to get Moderna and it got moved from Durham. And that's to make sure that everybody who lives in long-term care can be vaccinated before individuals who would be less at risk. So that's still the phase 1 group right now. This is phase 2. So it'll be people over 80 and it'll decrease in 5-year increments over the rollout, whether that means, over a month, everybody over 80 gets it, the next month it's 75 plus. We'll have to see how that goes. People who live and work in high-risk group settings, frontline workers, this includes teachers, as well as food processing, people with high-risk chronic conditions and their caregivers. So some of that has moved from phase 1, like I said, and other populations that are facing barriers, more rural and remote. Next slide, please. And then this is just a plug for our website. It's durham.ca/COVID vaccine. So this is where there's information there now, great information actually, but it tells you what's happening and what we're doing and what phase we're in. So if you were thinking, where am I going to go? How am I going to know when I'm going to get vaccine? This is actually where you would go, because there's a section, a drop down that says, how will I know when I get vaccine? So right now, there's not much information because we're still in the planning phase, but it's correct and it's current. But as soon as you are available in a sector, you will know from us, from the media, from news releases, from your family doctor, from your friends. So please don't think that you will just not know if it's your time to get vaccine, because you certainly will. Next slide, please. And these are just our regular good resources. That's our COVID cases, the data tracker I would drive you to. And then our COVID vaccines website is also great. And that's it for me. Back to Julia.
Great. Thank you, Dr. McTavish, for your remarks. Just a reminder to everyone to please enter your questions by typing in the chat feature or by pressing *9 for phone participants. It looks like we've got quite a few great questions already, so we can keep them coming. For our third presentation, I welcome Tiana Tilli, Director of Pharmacy Innovation and Professional Affairs with Whole Health Pharmacy Partners. Dr. Tilli received her Doctor of Pharmacy from the University of Toronto. While earning her degree, she participated in national and international health initiatives while interning at the World Health Organization, Ontario Pharmacists Association, and St. Mary's Hospital Lacour in Gulu, Uganda. Upon graduating, Tiana completed a hospital pharmacy residency at St. Michael's Hospital in Toronto. Following residency, Tiana was a health economics and outcomes research fellow at Becton Dickinson, Canada, where she provided her clinical expertise for their antimicrobial stewardship and medication safety portfolios. Tiana is now the Director of Pharmacy Innovation and Professional Affairs at Whole Health Pharmacy Partners, a banner of independent community pharmacies. Tiana leads the banner's clinical initiatives, including their adult immunization program and COVID-19 response. In addition to her role at Whole Health, Tiana is a clinical lecturer at the University of Toronto's Leslie Dan Faculty of Pharmacy, where she teaches and coordinates courses on medication therapy management. Tiana is a passionate advocate for immunizations and is optimistic that pharmacists will have a role in supporting Canada's COVID-19 vaccine rollout. Welcome, Tiana.
Thank you so much. Thank you so much for having me here today and for everyone for joining us this evening. We'll just move on to the next slide here. So I wanted to start by saying that myself and the members of my healthcare team are planning to get immunized as soon as it's offered to us and with whatever vaccine is available at the time. I know this is a question we've been getting from a lot of patients in terms of, well, what do we suggest and what are we ourselves doing? So I wanted to tell everyone in attendance that we have full confidence in this vaccine and we'll demonstrate that by getting whichever vaccine is offered to us. So we'll go to the next slide. So I think we're starting to see celebrities getting immunized, and it's good to get some of the word out and some buzz around it. If we go on to the next slide, what I think is even more important is that we're starting to immunize our frontline heroes. So we're seeing people in long-term care settings, in hospitals, in ICUs, even in shelters, really leading by example, not only being on the front lines, but also in receiving their vaccines. And having trust in the vaccines as well. We'll go to the next slide. So a lot of people ask what's involved in developing a vaccine, and just because it went so quickly, does that mean it's not very robust? And actually, despite it going so quickly, and we'll talk about some of the reasons why that was the case, there's actually quite a lot that goes into this and many phases of research and clinical trials. So we see that at the beginning, there were over 150 vaccine candidates. So everyone around the world was really dedicated to trying to find a vaccine, knowing that this plays a huge role in stopping the spread and keeping us all healthy. Now, as we moved over to things like phase 1 trials, where we injected immunizations into healthy young adults, we saw a smaller amount of vaccines that progressed to that phase. We then moved on to phase 2 trials where they're tested in a broader group of people. And again, that became smaller. We moved over to phase 3 trials where we actually looked at large international trials that tested the vaccine impacts on COVID-19. So in people who are actually exposed to COVID-19. And finally, in the approval process, we currently have 2 vaccines, the Pfizer and the Moderna vaccine, which have been approved, and hopefully some more to come. There are 4 types of vaccine technology. The ones that exist for the Pfizer and Moderna are a nucleic acid technology, and I'll walk us through what exactly an mRNA vaccine is. Some of the newer upcoming vaccines that are coming up, like the Johnson & Johnson one and the Oxford one, actually are a different type of vaccine, more the viral vector, and we can answer questions about that if those come up as well. Now, these trials that were required to get vaccine approval for both the Pfizer and the Moderna vaccine were very, very large trials. So typically a vaccine might come to market with a trial of maybe 6,000 to 8,000 patients included. For an example would be like the shingles or the Shingrix vaccine. Whereas when we look at the size of these trials, there are over 30,000 people included in the Moderna trial and over 40,000 people in the Pfizer trial. So we have a lot of confidence that we've observed the efficacy and the safety in very large groups of people already. In addition to now all the frontline workers who have already been immunized and who we're continuing to monitor afterwards. Okay, we'll go to the next slide. So mRNA vaccine technology. So vaccines in general, I like to think of like a fire drill where we're trying to prepare so that when there is a fire, we know how to respond quickly. So with these vaccines, we're getting the body ready to respond to COVID-19 in case it's ever exposed to it, so that it can respond really quickly. With mRNA specifically, mRNA is like a recipe. So it includes a recipe on how to make certain proteins. And these are proteins that are found on the COVID-19 virus. You might hear them called specifically spike proteins. And so once we give our body the mRNA or the recipe for making these proteins, the body then makes them in our own cells. And then other cells recognize that this is a foreign protein. And so it's able to mount an immune response so that once it has that response, in the future, if it's exposed to the real COVID-19 infection, we're able to respond much more quickly. So I'll walk you through this cycle here. So we have kind of the first step where the mRNA vaccine is injected. And it's important to note that mRNA cannot change your DNA. I like to think of mRNA almost like Snapchat. So as soon as it's read and it's used, it disappears. It's not very stable and it doesn't hang around for very long and it won't go into your DNA. The second step is that your cells read the mRNA instructions and they start building the same kind of spike protein that COVID-19 has. And if you've seen pictures of COVID-19, you see kind of those spikes all around them. Those are the real spike proteins. Next, your immune system sees those spike proteins and starts building a defense. And then finally, your body can recognize the COVID-19 spike proteins and fight COVID-19 effectively since you've been immunized. We'll go to the next slide here. Now, these are the 2 vaccines that we currently have available, the Pfizer and Moderna, and they're very, very effective. So across all age groups and races and ethnicities, we saw that the efficacy was 95% in preventing COVID-19 and 94.1% effective for the Moderna vaccine. For the Moderna vaccine, there was slightly lower efficacy in people who were over 65, but it was still very, very high at 86.4%. So these are much higher than we even see from other vaccines that exist in terms of how well they work. And so it's truly impressive that they were developed. I'll go to the next slide and I'll show you what this looked like in the clinical trials. So in the blue, you'll see those are cases of COVID-19, and those are in people who didn't receive the actual active vaccine. So they instead received a placebo, in this case, kind of a salt water. So here in the blue, we see the cases continuing to rise over time in both the Pfizer and Moderna in those who weren't immunized with the active vaccine. Whereas if you look in the red and the orange, those are patients who actually received the Pfizer or Moderna vaccine. And in those cases, the COVID cases really after about 14 days after the first dose, we already see that it stops increasing at such a high rate and then stays quite stable. So it is really impressive, the difference between those who receive the placebo and those who receive the active ingredient in the vaccine, and the efficacy there. We'll go on to the next slide. So you might hear that there's different vaccine administration schedules, and they'll change a little bit, but generally both of these vaccines require 2 doses, and they're injected into the shoulder muscle or the deltoid, the same way you would get your flu shot, for example. And you require both doses of the same vaccine. So if you received your first dose of the Pfizer vaccine, you want to make sure that your second dose is also the Pfizer vaccine. Same with the Moderna vaccine. If that's your first dose, it should also be your second one. Now, you might get the Pfizer dose about 21 to 42 days after your first dose. We're starting to see different provinces even extend this a little bit more to try to increase the number of people who get that first dose based on vaccine availability. But don't fret, you're starting to get protection even after. Just make sure you so that you Now, a lot of people ask what's in these vaccines. I know in general, there's a lot of concern about what goes into vaccines, and it can be broken down into 5 key ingredients, which almost makes it seem like you can make this at home because there's only those 5 categories, but they are more complex. The first key one, and I'll just get you to click on the screen, is nucleic acids. So that's the actual mRNA. Like we said, that's the part that's giving our body the recipe to make the protein that we want to mount a response against. The next one, and we'll click again, is lipids. So we want fats. The reason we want this is because that mRNA is so fragile almost that it needs to be protected so that it can stay in your body and get into the cells. So that's why we put kind of a lipid protection there. The next part is salts, acids, and acid stabilizers. Those make sure that the acid, that the vaccine is stable in our body and at a similar pH to our body's natural pH. The next one is sugars. And we want that because we're freezing this vaccine, and that helps to keep it stable in the frozen environment. Now, the last one is water, and that's really just so that we can actually inject the vaccine. Okay, on the next slide, I'll go over things that are not in the mRNA vaccines. And these in themselves are not dangerous to be in vaccines, but I know there's a lot of hesitancy in general, and so it's a nice plus that these aren't in the mRNA COVID-19 vaccines. So that includes things like preservatives, like mercury, which also explains why we have to use the doses so quickly and have certain storage requirements. There's also no gelatin or food products, no pork-derived materials, blood fractions, or fetal cells. And so that means that in terms of any religious restrictions, we don't see issues here. So many religious organizations have actually publicly spoken out, encouraging COVID-19 vaccinations, and these are not included in the vaccine ingredients in case that's a concern to you. We'll go to the next slide here. Now, a lot of people think of the benefits of COVID-19 vaccines in terms of protecting older people or people with other clinical comorbidities, but it's also protecting healthy younger people. We see that those people can also get sick. And if you get sick, even if you don't pass away from COVID-19, we're already seeing long-term complications. So we're seeing things like damage to lungs, to people's hearts, memory impairment, feeling tired and fatigued for long periods of time. So even if we're not concerned ourselves about passing away from COVID-19, we need to be concerned about these potential health impacts and also protecting our loved ones. So these COVID-19 vaccines stop the spread of COVID-19 and also reduce how sick somebody who does get COVID-19 ends up being. It helps us protect ourselves, our loved ones, our frontline and essential workers. It's also what's going to let us return to work, school, reopen businesses, resume our hobbies, things we enjoy, traveling, visiting family and friends. So it's really important for our overall kind of lifestyle as well. And we'll go to the next slide here. Now, some people have noted that there are vaccine side effects, and that's very normal with vaccines. I like to think of this one like you're going to the gym and you're working out and you're building muscle, but then the next day your arms feel tired, and that's because you're getting stronger, but it's made your muscles a bit tired. And so in this case, very similarly, we're getting immunized, we're becoming stronger, but we can feel that a little bit through the side effects. So the side effects tend to be mild to moderate, and they last about 1 to 3 days on average. At the actual injection site, you might get things like redness, a bit of soreness, pain, or swelling. And then overall in your body, you might get things like feeling tired, like you have a headache, some muscle or joint pain, or maybe a bit of chills or fever. There is a low risk of severe allergic reactions. It's a very small number of cases, and this tends to be in people who actually have a history of anaphylaxis. One of the ingredients that's specifically causing these allergic reactions is PEG. It's one of the fats that protects the mRNA. Now, there's a way to find out if you have PEG allergies, and that's to see if you've ever had a product, for example, that has PEG in it. So a lot of people use PEG potentially as a laxative. It's also in Tylenol, extra zinc tabs. It's in ibuprofen capsules. It's in different over-the-counter medications. So a lot of people have probably taken this already and are completely fine. They don't have an allergic reaction. But anyone who is providing an injection would be trained to respond even to severe anaphylactic reactions. We'll go to the next slide. These are some key tips about still staying healthy. Even if you get your COVID-19 vaccine, other people haven't yet been immunized. So we need to keep practicing all our physical distancing measures and following requirements and recommendations on staying safe and healthy. We'll go to the next slide. One important thing to know is that your maximum protection is going to be achieved 1 to 2 weeks after your second dose of the vaccine. So do make sure you complete the vaccine series. One of the things you can do to make sure that's done is that you keep a record of being vaccinated. Keep the piece of paper they might give you, take a picture of it just in case you lose that piece of paper, record it in the Immunize Canada app, and make sure you know what date you were immunized on and which of the vaccines you received, because you want your second dose to be that same vaccine you received the first time. This can be especially important if you're caring for older people who might have memory impairment, or even keeping track of your parents. You want to keep track for them as well. We'll go to the next slide. Now I'll touch on 2 frequently asked questions that we're already getting quite a bit. The first is in special populations. So there were certain populations that weren't included in clinical trials. And so it's going to take us a little bit more time to get some safety and efficacy data, but we can make some decisions already. So in pregnant and chest or breastfeeding individuals, they weren't included in the trial, but the trials didn't exclude anyone who was going to get pregnant. So this means when they enrolled in the trial, nobody was pregnant or breastfeeding, but they may have become pregnant as we were following with them. So we will get data further along the lines when we know about those people who were immunized, what happened afterwards when they had children, for example. We do know that COVID-19 carries a risk both to the mom and to the fetus or the baby. And so it is important to be protected and to make that decision. There's no theoretical reason why this should be dangerous, for example, to infants who are chest or breastfeeding. And if you have any questions, you can ask your healthcare provider about your specific case, but there are recommendations to get immunized as long as you think about it for yourself with your healthcare provider. In terms of people who are immunocompromised, trials didn't include people who are on medications like biologics or who have immunocompromising conditions like cancer, but they did have some conditions like people who are HIV positive. And so we'll start getting more data there as well. In the case of mRNA vaccines, we're just using mRNA. So it in itself couldn't infect someone with COVID-19. And so there are recommendations, again, to make that decision, especially since we know that immunocompromised people are at greater risk of COVID and associated complications. There's one group that we're not immunizing yet. Those are children and youth under 16 years. The reason for this is they also weren't in the trials, but we know that people in this age range actually have a stronger immune system. And so typically they can have, that can trigger a stronger immune response. And so we end up usually using different doses or dosing schedules. And so we need to figure that out before we start rolling it out in people under 16 years. We'll go to the next slide. The next question is, can we trust the vaccines given how quickly they were developed? And I want to assure everyone that no steps were skipped in the process of developing, testing, approving, or producing the vaccines, and that Canada has one of the best vaccine safety programs and has a really rigorous independent approval process. The reason why we saw such quick development is because we had never before seen levels of international collaboration and funding. We also had situations where multiple steps were being planned and run simultaneously, where there'd usually be large delays between trials, for example. And this can be because at the beginning, we can't plan everything because it risks too much money, for example. But in these cases, the development was prioritized over financial restrictions. We also saw, like I said, really large clinical trials that we haven't seen previously. And we also used a technology that already existed. So while there weren't mRNA vaccines before, there was mRNA technology used in things like cancer therapy. And lastly, there have been other coronaviruses. And so those gave us a bit of a head start in studying and understanding these viruses. And we'll go to the next slide. These are some key points, and then on the next slide, I have some resources in case anyone wants to read more or access them for themselves, and we'll just go to that slide now as well. So thank you very much.
Sorry about that. Thank you, Tiana, for your remarks. Just a reminder that questions continue to be accumulated throughout the presentations by using the chat feature or by pressing *9 for phone participants. Staff will follow up with customers for any questions that remain unanswered. So it's now time for our Q&A portion of our event. So I'll ask our speakers if they could please turn on their cameras and we will start the questions. Okay, so the first question is, will we have the opportunity to determine whether we are immune naturally? Are our potential natural antibodies less effective than the antibodies from a vaccine? And do we get tested after being vaccinated to determine if we have actually developed antibodies? Tiana, did you want to speak to that?
I can start, or doesn't matter, but I would say right now, sorry, if you have had COVID-19, or even if you may have COVID-19, we still want to make sure that you get immunized. We don't know how long your immunity or protection might last from actually having COVID-19. So we want to make sure that you still get immunized to make sure that you have that ongoing protection.
Great. The second question is, if I have a severe allergic reaction to an antibiotic, should I be concerned about having a reaction to the vaccine?
So in the actual vaccines, it seems to be more the PEG component, that lipid or fatty component, that wouldn't be something similar to an allergic reaction to antibiotics. So I think a good thing to test it would be seeing, have you ever taken a Tylenol extra strength or Tylenol capsules or Advil capsule, liquid gels, for example. Those all have PEG. And you can even see some of your over-the-counter medications if they have that. But an allergic reaction to an antibiotic wouldn't be something that we'd be thinking would make you more likely to have an allergic reaction to the vaccine. It's also important to really think about what we mean by allergies. So some people might experience allergies as or interpret allergies as maybe like a rash or an upset stomach, for example. But what we're really talking about is anaphylaxis. So that would be people who tend to carry EpiPens. And those are people who've experienced things like swelling of the throat, the lips, difficulty breathing, hives, that kind of thing.
Great, thank you. The next question is, if you are living with a lung condition such as COPD, is that considered a chronic condition, and would that be a barrier to vaccinate?
I mean, I think any of us can.
Already, Dr. Ricciuto, you can start.
Sure. Yeah. I think any of us can answer. So COPD is a chronic condition, but it's not a barrier to vaccination. It probably is a reason to get vaccinated because we do know that people with chronic conditions are more susceptible to getting more severe COVID-19 infection. So it's all the more reason to get vaccinated in that circumstance, and definitely not a contraindication.
Great, thank you. The next question is, when it's our turn to get vaccinated, do we have options to choose the vaccine we would prefer?
Unfortunately, no. We in the community will get whatever we get from the province, whether that's Moderna or whether it's the new AstraZeneca. So there won't be sort of a mix and match. We'll be sent what the federal government has bought and then gets distributed to the provinces, unfortunately. But like Tiana said, they all sort of work similarly. So we get what we get. Yeah.
And for Dr. Ricciuto, do you have numbers of ICU beds utilized last year at this time, and is it drastically different?
Yeah, good question. So off the top of my head, I don't have the numbers, but just reflecting a little bit. So the province increased the funding for ICU beds. So we actually have about 20%, 30% more beds overall. We normally, if normally it's a flu surge, we're not seeing any cases of influenza, thankfully, otherwise it would be a real disaster. But normally it'd be a flu surge right around now, and it's typically one of our busiest times. And we're normally about 90% full at this point in time. But so now with our addition of 20 to 30% more beds, we're still around that 90 to 95% capacity. So, I guess if you try to compare from last year, we're probably 20% more overall. Some hospitals are much harder hit than others. There's been a number of hospitals that have had to transfer patients out of their ICUs to other hospitals that don't that do have room because of this. That's not a usual thing that happens during flu season, for instance.
Great, thank you. And for Dr. Ricciuto as well, is there anything we can do naturally to strengthen our immune systems?
Yeah, so I mean, I don't think that there's anything that you can do that would be equivalent to getting the vaccine. It's still the number one thing that when available you can do to get it. And echoing everything that Tiana said, I rolled up my sleeve when I was able to a couple of weeks ago to get my first dose. And we'll be finishing that whenever the second dose becomes available. There's a little bit of data, and again, it's not really strong evidence. So, I hesitate a little bit to recommend, but there's a little bit of data about vitamin D supplementation, which normally has sort of an effect on the immune system. And so there's some sort of let's say poorly conducted studies or non-randomized control studies suggesting that there may be some benefit to vitamin D supplementation. There's less evidence for other things like zinc, for instance, but vitamin D would be something. Most Canadians are vitamin D deficient anyway, especially during the winter months. So it's typically not a terrible thing to do anyways.
Great, thank you. And for Dr. McTavish, when will vaccinations occur for Durham residents?
So great question. I would hope in a month we will get vaccine and start to see vaccine in the community. Maybe 6 weeks. I'm hopeful for a month. We've been told when it lands, it's going to land. Like, we're not even going to know how to store it all, right? It's going to show up and we're going to have to figure out how to keep it all cold. It's a good problem to have, and we'll figure it out when we have it. When we get it, I'm hoping a month. Yeah,
Great.
and then that'll be that high priority, the phase 2 people in the community. So seniors who are 80 plus, it might come down a little bit, like we've seen. Update that web page because it can change based on vaccine, congregate living. And again, it'll be who comes first based on how we can get the vaccine out. For example, the mobile piece may be faster, maybe it'll be slower, maybe the mass vaccine clinic happens first. And hopefully it all happens at the same time, right? Hopefully pharmacists are involved and your family doctors or nurse practitioners, and we have the mobile clinics and we have a mass vaccine clinic. So although it's a phase 2, hopefully it's a phase 2 all at once, if that makes sense. So hopefully soon.
Great, thank you. And also for Dr. McTavish, why are seniors who live independently not prioritized like in other provinces? And in which phase will seniors over the age of 75 be vaccinated?
So I would say you are prioritized for sure. You're prioritized in phase 2, and you'll be the first group immunized as soon as vaccine comes to the community. So you are prioritized. It might be a little bit different than other provinces, but you're certainly prioritized here.
Great. And for Dr. McTavish again, how will Durham Region ensure that there are enough second doses for everyone to receive within the recommended time frame?
So great question, because we have to. So you have to hold back enough doses that people can be assured they get their second dose. And that's, you may have heard in the news that that's been a little bit of chatter about, well, why can't we just give everybody one first dose and then have everybody, partially protected, as opposed to holding vaccine back and waiting. But I think a great example of why that was good that we didn't do that is the supply chain issues, right? Like all of a sudden we're out of, there's no Pfizer this week or drastically reduced. So if we had gone ahead and given everybody one dose, and then now we don't have enough to give everybody the second dose as it's recommended, we're really in a tight spot. So you have to hold back enough doses so we can ensure that everybody who gets a first dose will get a second dose. So please don't be concerned about that. If you got a first dose, you'll get a second one.
Great, thank you. And for Tiana, is it known yet how long one will be protected by the vaccination?
So because these were developed so recently, we're still ongoing and monitoring it. So trials are ongoing, they're still monitoring that. So we don't know how long the protection will last. It's something that will be continued to be monitored, and we'll have more information as more time elapses.
Great. And this could be for anybody who would like to answer. What is the period of time after receiving the vaccine that one could have an allergic reaction?
I can take it. So this has actually been recently studied, and the CDC has done some studies of both the Pfizer vaccine and the Moderna vaccine after a number of doses. So after a couple million of the Pfizer vaccine doses, they showed about 1 in 100,000 people will actually have an anaphylactic reaction, which is actually higher with that vaccine than other things like influenza. The majority had a reaction within 15 minutes. Also, our monitoring currently, that is to monitor for 15 minutes after your vaccine, so we capture the majority. There are some people that are at higher risk, for instance, that have potential reactions, or have anaphylaxis to other things, whereby you have to carry an EpiPen, for instance. And those people we tend to monitor for longer. We monitor for 30 minutes to make sure that they're captured. And just along those lines, with the Moderna vaccine, the recent analysis of about 8 million doses, they found about a 1 in 400,000 rate of anaphylaxis, which is closer to other vaccines, maybe a little bit higher, but still very, very rare event.
Great, thank you. Is there any research on the safety of the vaccine for people with neurological disorders such as Alzheimer's disease or Parkinson's disease?
So yeah, I'll comment out, and Tiana or Pepi can fill in. As far as I'm aware, I haven't seen anything pulled out specifically for these populations. I will say that the at least the rollout of the vaccinations across many countries and Canada has included, the elderly as a priority, including long-term care residents, many of which I think would have underlying Alzheimer's and or Parkinson's. And we've not seen any signal for harm in those groups, but I have not seen anything very specific related to that. I don't know if either Pepi or Tiana have.
I haven't either. Not sure if Tiana has.
No, I haven't seen anything specific, but just knowing that some people in Canada who have these conditions have been immunized already.
Great, thank you. Does the vaccine protect against the new strains of COVID-19 that we've been seeing lately?
So I'll comment because I comment on this a little bit with the variants of concern. So there have been some reassuring data with respect to the UK variant, at least. So the way that they've done these studies is they've taken antibodies from people who have been vaccinated, for instance, with the Pfizer strain, and exposed it to the virus, and they show that it is able to neutralize that virus. I mean, it does seem to work against that virus. We're still waiting for better real-world data, but it seems like it works against that UK variant, that B.1.1.7 variant. So that's reassuring. There is, however, some suggestion that it may not work as well against the other variants, the South African variant or the P1 variant from Brazil. It seems like there's still some coverage there, but the level of antibodies that you get are not as high. And we know that over time, the antibody levels start to go down. And so I think there is some concern amongst the medical community, and just because we don't know yet, is it possible, for instance, that even if they work up front, is it a relatively short time period before you need a booster to get your antibody levels higher, or do you need to be revaccinated against these other strains in the future? And just to note that actually both Moderna and then there's a couple of other vaccine producers, another mRNA producer, are already creating updated vaccines in order to target these new strains, just in case. The great thing about the mRNA technology, which really is incredible, and what they've been able to do to produce these really effective vaccines. The one good thing about it is that you can tweak it relatively quickly, not change the actual technology, but you actually can change the protein that your body is seeing from the virus, and so therefore protect you against new strains in the future if needed. So anyways, that was a bit of a long-winded answer to say we're not totally sure yet, but at least there should be some protection.
Okay, great, thank you. And for Dr. McTavish, I believe you touched on this briefly, but how will people know when it will be their turn to be vaccinated? Will they be notified in some way, or is it just more a matter of keeping an eye on the media?
Good question. Definitely the media. I mean, I feel like you'll just know. There'll be provincial direction, there'll be news releases, there'll be, Ford will have his 1 o'clock presser. That'll trickle down locally. Dr. Kyle will do media. He does a lot of media at 6 o'clock news. You'll find out because we'll send information through our usual channels to your family doctors, so they'll know your local physician. To community groups, we'll put it out through municipalities. So you will please don't feel like you miss your opportunity. You will certainly know. And we will target, for example, if there's like seniors community centers and that's where we're going to run a mass vaccination clinic, it would be fanned out through your usual means of communication, whether that's an email distribution list. So you'll probably actually get annoyed with how many times the vaccine will be available to you once you get it. So please don't worry that you'll miss out on hearing about vaccine when it's available to you.
Great, thank you. And the next question is, you've mentioned the long-term side effects. Is there any chance of these noted long-term side effects resolving themselves as more time passes, or is it permanent damage?
I don't know if that was me or someone else. So I think we're talking about the long-term effects of COVID-19 infection, right? And I guess clinically, I'll just chat because I am an infectious disease specialist too, and I happen to received a number of referrals for people who have had COVID and have developed these long-term effects, sort of called long hauler syndrome or long COVID. And it's basically like a type of chronic fatigue syndrome that does develop. And this happens after other infections as well. However, it seems to be fairly prominent amongst people that have had COVID and not even COVID that was severe enough to hospitalize them. So there've been now a few studies trying to look at how long these effects last for. So on average, people that are sick enough to be hospitalized with COVID, they tend to still have symptoms even a month out on average. But the people that have the long hauler effects, they which is a small percentage, they can have effects or symptoms out, 3, 4, 5, 6 months. So let's say that each month that goes by, the number of people that are still suffering from symptoms goes down, but there are still some people that have been infected during the first wave experiencing symptoms to now with only mild or gradual improvement. So it's still something that's being investigated where we have like really good data in the longer term, because we're only 9 months out or so from the first wave. But I'll say the majority of people do get better. Often it takes, for people who have significant symptoms, it often takes up to a month before you're back to normal. And then there's some people that take a little bit longer to get better, with only a few people that have lasting symptoms beyond, let's say, that 6-month time frame.
Great. And I'm not sure if this is a question, it's more of a statement, but it says an allergy to ibuprofen will not allow me to be vaccinated. I have an EpiPen as well. Does anyone want to comment on that?
I would say to talk with your primary care provider. So if you have a family doc or a nurse practitioner, just to really suss out the nature of that allergy and what in the ibuprofen it is that you might be allergic to, and have them help you make that decision in terms of what your risk is and what they recommend for immunizing you. They might have certain setups where there's more intense monitoring, but it could be possible. So I would say have that one-on-one discussion.
Great, thank you. And for Dr. Ricciuto, why does the virus affect more males than females?
Yeah, so this is something that is a definite risk factor with a significant increase of more severe disease in men than women. So it's actually not completely known yet, but there's a couple of hypotheses. So one is potentially that the type of cells or the way that the virus gets into cells is through a receptor. It's called ACE2, and there's some suggestion that men have a higher density of those receptors on their cells, so it may be that the virus is more easily able to get in. The other thought is that for some reason that there might be sex differences in and the immune response, which tends to be what makes people really sick with COVID. So most patients that get really sick with COVID, they actually, have symptoms lingering for 5 to 7 days before they actually start to get really sick. And then it's usually around day 10 to 14 when they're the sickest. And this is around the time when the immune response takes off. So it's not so much that the virus is overwhelming the body, but the immune system goes haywire and causes a lot of inflammation, which results in the lung damage. And it seems like men are more likely to have that type of really exaggerated immune response. And otherwise, I think we're still learning as to exactly what the differences are, but those are two possible reasons.
Great. And the next question is, I've heard low-dose aspirin is helpful due to the clotting issues associated with COVID. Is this true? Dr. Ricciuto?
Yeah, I can answer that. I've not seen any data with aspirin. So one of the ways that COVID does make people sick is it does make the blood vessels sticky and inflamed, and so you can get clots. You can get big clots, like clots that go to your lung, DVTs or pulmonary embolism, or you can get little clots, and that sometimes happens when people are really sick in their vessels. It would make some sense that aspirin may help, but I've not seen any data suggesting it actually makes a difference. That said, in hospitalized patients, we do know that the type of blood thinner that we use to prevent clots in most hospitalized patients, that medication does seem to help people to prevent them from getting clots. And there's actually a couple of ongoing studies looking at whether or not higher dose blood thinners, if you're sick enough to be hospitalized, make a difference. But the aspirin alone, I'm not aware of data.
Great. And the next question is, how will shut-ins be vaccinated? So anybody that's homebound and really isn't able to leave their home? Dr.
Great
McTavish?
question. Yeah, so that's where we're looking at the mobile clinic. So let's say it's, you know, for example, like a building geared towards seniors living, maybe people could get down in their elevator and come down to the main floor. We run a clinic there. But certainly if people can't get out, we will find a way to get to them to provide vaccine, just like we did in long-term care and retirement homes. So I've seen a couple comments about, well, how will I actually sign up? And I know I'm not addressing that, so sorry, I didn't mean to skip over that, but we haven't figured that out yet, because we hope it'll be an online registration system where you will get a link and it'll say, come, you know, pick your time. Because unlike mass flu vaccine clinics, you can't just show up, because we need to then be able to book you for that second dose. So maybe it's a show up for the first one and we figure it out, or maybe it's when you register for one, you register for the other. So that registration piece has to be figured out. And we know that not everybody has access to the internet or a smartphone or their computer. So certainly there'll be a way to still phone, speak to an administrator and book. So that piece hasn't been figured out yet, but again, you will know and you will be able to book. And if you can't get out to get your vaccine, we will find a way to have vaccine come to you in the community.
Great, thank you. The next question for Dr. Ricciuto, I understand that people who have been sick with COVID still need to be vaccinated, and how much time should pass before they're vaccinated?
Yeah, that's a great question. And so a couple of thoughts. So it seems that people who previously have COVID do have some immunity. There's recently just a study published of healthcare workers that had COVID, and they followed them over the course of 5 months, and they showed about 80% protection over those 5 months. So that's good, but it's also thought that the immunity from natural infection, so if you get COVID, it probably comes down faster than it would with vaccine-related immunity, and so which is the recommendation for getting the vaccine. The timing of it is a little bit tricky because nobody knows exactly when. I think we can say that you do not want to get your COVID vaccine if you're still recovering from your acute illness, from your COVID illness. So you want to be fully recovered. You know, the timing of that sort of depends. You know, it could be 6 weeks, it could be 12 weeks before you go for your vaccine. That said, you know, I don't want to say you can be 100% confident that you're immune at 12 weeks, but it's likely if you're 12 weeks out from having an infection, you're likely going to be at least partially immune. So there's not a huge rush in getting it, you know, the week after you've had your COVID. And so I think you just have to kind of keep it in mind. Right now, there's no rules about that other than you should feel well. There should be no ongoing illness at the time. And part of the reason for that is that when you have another illness, the vaccine just may not work as well. And this is the same as goes for any other vaccine, right? So if you have a febrile illness and you go in for or you bring your children in for their routine vaccinations, it usually postpone those vaccinations until that illness is over, and it's somewhat similar there.
Great, thank you. And for Dr. McTavish, my family doctor is in Scarborough. Will I be able to get my vaccine in Durham?
Yes, of course. Yeah, I mean, if your family doctor gets vaccine and you would like to receive your vaccine through your family doctor because you have a relationship and your family doctor gets vaccine, you're welcome to get it either place. Just please get vaccinated.
Great, thank you. And also for Dr. McTavish, how prevalent is the new strains for a number of cases in Durham?
So good question. That number will be reported out by the end of week by Public Health Ontario. But as of end of day today, we have 7 confirmed cases in Durham. I believe there's, actually I don't know the provincial number right now, That's not a secret. It just hasn't come out yet on the provincial dashboard, but Public Health Ontario will be reporting it daily. So Dr. Ricciuto said they're doing some screening tests now. We're trying to take a snapshot in time with how many people actually have this. So we're still in containment mode in Durham, so it's not the most prevalent strain. So people who have the UK variant, the B117, we're just doing more intensive case and contact management. So they really have to make sure they stay home. We have to really be careful about who they've been in contact with. But we're doing everything we can right now to make sure that those cases stay contained and it doesn't become a dominant strain in community. Whether that horse has left the barn or not remains to be seen. But it's certainly in Durham Region.
Great, thank you. And how many ICU beds does the Ajax Pickering Hospital have? Dr. Ricciuto, do you know?
I should know this off the top of my head. I think it's 14. Do not quote me, but I'm pretty sure that's the number.
Okay, great. Well, I believe that is all the questions for this evening. So a huge thank you to our three speakers, Dr. Dan Ricciuto, Dr. Pepi McTavish, and Tiana Tilli. Thank you so much for sharing your expertise with us tonight and for providing such valuable information that will help each of us cope with COVID-19 in our community. And thank you for all the attendees for participating in the forum tonight. Before the end of the forum, we do have a quick poll that you can answer as you are exiting the program, and I will launch that now. It is anonymous, but we would love your feedback. To watch this event again, please check our respective websites in the next few days, and thank you, and good night, everybody.
Thanks, Julia. Thanks, everybody.
Bye, thank you.
Great questions.
Thanks, everyone.